Assalamu alaikum. Today we will talk about facial nerve paralysis. At first, let's get a rapid glimpse into the anatomy of the facial nerve. As we remember, facial nerve nucleus is present in the bones. Facial nerve pass from the facial nerve nucleus, passing from the bones to the internal orifice of the internal auditory canal, what we call internal auditory meatus. Then it will pass through the internal auditory canal till it reach to the middle ear cavity, where it turn backward, forming what we call first genio with the facial nerve. Then it will then it will pass, forming the transverse segment of the facial nerve until it reach to the posterior wall of the middle ear cavity, when it again turn downward, forming the second genio of the facial nerve, and passing downward, forming the vertical segment of the facial nerve. Then after emerging from the stylomastoid foramen, the facial nerve enter into the parotid gland. Then it will branch to external branches, which are the temporal branch, zygomatic branch, buccal branch, mandibular branch, and cervical branch. The types of fiber in the facial nerve vary from its main function or its main fiber is motor fibers to the muscles of the face. So it's called the facial nerve because it's a motor to the facial muscles. However, the facial nerve during its course it carry many other fibers. For example, it will carry secretomotor fibers to the lacrimal gland, which leave the facial nerve through the greater petrosal nerve from the first genio. Also, it will give off branch to the stapedius muscle, which usually is responsible for what we call the stapedia reflex. Stapedia reflex is a reflex when we expose to high voice or a loud sound. To protect the inner ear from this loud sound, the stapedius muscle will contract, cause fixation of the stapedius, so it will protect the inner ear from this high energy. This protective mechanism is called the stapedia reflex. Also, the facial nerve carry the chorda tympani nerve, which carry taste sensation from the anterior two-thirds of the tongue. It will also give off secretomotor fibers to the submandibular and sublingual glands. Clinical manifestation of the facial nerve palsy. The most important manifestation is loss of the function of the facial muscles. So, inability to raise the eyebrow, loss of wrinkles in the forehead, inability to show the teeth, usually dribbling of saliva and food from the angle of the mouth, inability to blow the cheek, and lastly, inability to breathe the ankles. Facial nerve injury may be upper motor neuron or lower motor neuron. As we know that any cranial nerve, after emerging from its nucleus, this is what we constitute the lower motor part of the cranial nerve. Usually, the facial nucleus is under control of the cerebral cortex. The cerebral cortex exerts its control over the facial nucleus through what we call the corticobulbar tract. Any injury in the cerebral cortex or in the corticobulbar tract, this is what we call upper motor neuron lesion. Any injury in the facial nucleus or distally, this is what we call lower motor neuron lesion. The main difference is that the facial nerve nucleus, as we can see here, this circular part represents the upper part of the facial nerve nucleus, which supplies the upper half of the face, or in other words, the upper quadrant of the face. This nucleus usually has bilateral supply from the cerebral cortex on both sides. So, if you have upper motor neuron lesion for any cause or cerebrovascular accident, this nucleus will preserve its supply from the other side. So, in case of upper motor neuron lesion, the lower part of the facial nucleus will lose its control. This will cause paralysis of the lower quadrant of the face, while the upper part of the facial nucleus will still have its control over the upper quadrant of the face. So these patients will have only paralysis of the lower quadrant of the face, while in case of lower motor neuron lesion, the whole half of the face will lose its function. This is an example for the comparison between upper motor neuron and lower motor neuron. In both cases, there is a right side facial palsy. As we can see here on the left side, the patient can close his eye because the upper quadrant of the face is still functioning. While in lower motor neuron lesion, as we can see in this lady, she was not able to close her eye. Causes of facial nerve palsy for upper motor neuron: any cerebrovascular accident, brain tumors, multiple sclerosis. Lower motor neuron lesion may be divided into nuclear lesion. Then after emerging from the stylomastoid foramen, the facial nerve enter into the parotid gland. Then it will branch to external branches, which are the temporal branch, zygomatic branch, buccal branch, mandibular branch, and cervical branch. Ear. Extracranial causes usually is due to injury in the facial nerve after its emergence from the stylomastoid foramen. Usually is related to the parotid gland, face wounds. Forceps delivery at the birth injury actually is not present nowadays. Usually in old times, if the patient is locked or obstructed during labor, usually doctors or was using forceps or ventouse to pull the baby out. However, nowadays usually it has been compensated or has been replaced by cesarean section. Post-auricular incision in infants, as we know that the problem in infants that the mastoid is well not developed. So in case of post-auricular incision for ear surgery, iatrogenically or accidentally, injury of the facial nerve may occur at the tip of the mastoid. In the level B, in such case, the function proximal to that level, which is the lacrimal secretion, will be preserved. So, if you do Schirmer test, you will find normal lacrimation. But all other function, as stapedia reflex, taste sensation, facial muscles movement, all will be lost. If the injury occurs in the level C, so the proximal function will be preserved, so the lacrimation and stapedia reflex will be preserved, while taste sensation and facial muscles expression will be lost. If the injury occurs at the level D, all the proximal function will be preserved, so the lacrimal secretion, stapedia reflex, and taste sensation are preserved, while the movement of the facial muscle will only be affected. This is what we call the topographic diagnosis. This is an example for the comparison between upper motor neuron and lower motor neuron. In both cases, there is a right side facial palsy. As we can see here on the left side, the patient can close his eye because the upper quadrant of the face is still functioning. While in lower motor neuron lesion, as we can see in this lady, she was not able to close her eye. What about the treatment? There is a general treatment. Care of the eye. As we know, one of the main problems in the facial paralysis, even if it's a temporary pathology, that the eye is exposed. Eye should never be exposed because exposure of the eye to the air usually leaves the eye unprotected, causing dryness of the cornea. This may cause corneal ulceration and permanent visual disability. So, you have to protect the eye. by using eye drops or eye ointments, eyeglasses to protect it from the light. Tarsorrhaphy is a surgical closure of the eyelid. If we expect that the pathology will remain for a long duration, the ophthalmologist may do an operation in which they close both eyelids together to protect the cornea until the function is regained, or what we called gold weight implants, in which the ophthalmologist will put a weight implant in the upper eyelid, causing the upper eyelid to close over the lower eyelid by weight, thus protecting the eye till the facial function regained again. Number two, care of the muscle. If you leave the facial muscles without movement, these muscles may undergo atrophy. You know that there is a general rules in the body, what we call disuse atrophy. You should not leave any muscles without movement. This is the function, or this is the care of the muscles. I can do it passively or actively. Passively through the massage, actively through electrical stimulations or physiotherapy. Facial rehabilitation, usually this is done in the irreversible cases. For example, if the patient has a facial tumor and we excised that tumor with part of the facial nerve, so I can expect that the patient will be permanently disabled and the facial muscles or the facial function will not regained. In this case, we will think about what we call rehabilitation surgery. Usually it's a plastic surgery carried on by a plastic surgeon in a trial to improve the appearance of the patient, or even in a trial to move the muscles of the faces using a muscle transfer or nerve transfer or nerve anastomosis. The details is not important. You have only to know that if the case is irreversible cases, we do a surgery, what we call the facial rehabilitation surgery or facial reanimation surgery. Then treatment of the cause if it can be treated. For example, if you have an acute otitis media, you should think about meningotomy. For Bell's palsy, as we will take within a few minutes, you should use steroid and antiviral. In some cases, exploration and decompression of the facial nerve may be mandatory. What is Bell's palsy? Bell's palsy is the commonest cause of facial nerve paralysis. It's characterized by being acute in onset, unilateral, usually associated by lost stapedial reflex causing sound intolerance or hyperacusis, pain around the ear. Bell's palsy is the idiopathic facial paralysis. Usually it's a diagnosis of exclusion. I can diagnose it after excluding all other causes of facial paralysis. Pathophysiology is most probably due to edema of the facial nerve inside its bony canal. Actually, the etiology is not known, however, there is a number of theories. It may be viral infection, vascular disease. Treatment usually is in the form of general care, as we talked before, care of the eye, care of the muscle. Number two is oral corticosteroid. This is the main line of treatment because, as we said before, whatever the etiology, the pathogenesis is the same. There is edema of the facial nerve, and the most potent anti-edematous agent is corticosteroid. So, corticosteroid is an important as a line of treatment of Bell's palsy. Antiviral drug, this is based on the theory of that viral infection may be a cause of facial paralysis. Nerve decompression as indicated by electrophysiological test if these patients show no improvement after a maximum of 6 months, or if the electrophysiological study revealed that more than 90% of the facial fibers are affected, so I can think about nerve decompression. As we said before, the main pathophysiology or the pathogenesis is the nerve being compressed inside its bony canal. The aim of the surgery is to drill out the bony canal, leaving space for the facial nerve to swell or to avoid compression of the fibers against itself. That we call uncapping of the facial nerve or decompression of the facial nerve. This is the end of our lecture about the facial paralysis. Thank you for your attention.